difficult airway, neuroanesthesia, and ATLS training. Welcome, ma'am. Over to you, ma'am, for the proceedings of this session.
Thank you, Nitin. It's my pleasure to invite Dr. Raj Sarjanandan. He is a professor and head at CMC Vellore. I have had an old association with him, and it's my pleasure to invite him to see him at this platform. His area of interest is cardiothoracic, anesthesia, airway, simulation, and perioperative ultrasound. Worked with him when he was a postgraduate at Maulana Azad Medical College. And my pleasure to call you over, Dr. Raj. You can start your talk.
Thank you, Dr. Akhilesh and the organizers of APPEC 2023 for this opportunity. The next 30 minutes, we'll talk about the overview of lung isolation techniques. Coming to the indications of one lung ventilation, we do it primarily when you have to protect the healthy lung from infected material, blood or fluid, like bronchiectasis or lung abscess, or in certain cases where you have doing a therapeutic whole lung lavage. Diversion of ventilation from damaged airway or lung, for example, the bronchopleural fistula or bronchopleurocutanous fistula, and when you need to improve the exposure surgical field. The absolute indications will be a VATS or pneumonectomy, and a low priority indication will be an esophagectomy. The options available to us are double lumen tube, which is still the gold standard, the different bronchial blockers, and endobronchial tube or a single lumen tube, which are specialized tubes which are available earlier and now. Coming to the types of DLT, you can have different types of DLT like Maringrot, Sheridan, Silbronco-Clini, or a Naruke tube. Coming to the basic pattern of a double lumen tube, you can see that there are two tubes attached side by side with each other. It has got a tracheal limb, which ends proximally, and a bronchial limb, which goes distally. So this is meant to go beyond the carena, which the carena is normally at this level, into the bronchus. And it has got a proximal tracheal cuff with a pilot balloon and a distal bronchial cuff. So this will be like the newer Maringrot or a Cortex tube, and this is the older red rubber tube. Okay. So there are two types of tube which are available. One is the right-sided tube, and the another one is a left-sided tube. The basic difference is that for a right-sided tube, we need to have an arrangement so that the right upper lobe is ventilated bar collapsed. So the shape of the cuff, unlike the left-sided tube, you can see that it's a spherical cuff. Here you have got a donut shaped cuff, and you have got a stop for ventilation of the right upper lobe. You can see that very clearly, and you can see the donut shape also very clearly. So the first question we need to answer is whether you're going to go for a right-sided tube or a left-sided tube. So the common dictum is that most common use tube is a left-sided DLT. This is because it has got a better margin of safety. However, there are certain indications where you select a right-sided DLT. For example, when you have an extrinsic compression of left main bronchus, whether it's a tumor, aneurysm, or when you have an intrinsic obstruction of the left main bronchus, whether it's an intraluminal tumor or a stent in situ, left-sided pneumonectomy. However, you can do the pneumonectomy if you've got a good communication with the surgeon with a left-sided DLT. What we need to do is, before the surgeon goes and clamps the bronchus, you need to withdraw it into the trachea. Other indications are left lung transplant, left-sided tracheobronchial disruption, or left-sided sleeve resection. So what I will say is that if you're going to plan a right DLT for the first time in a critical situation, you may struggle. So when you get an opportunity that when you're doing a left-sided surgery, and if you have the fiber optic, go for a right DLT. So it's important to have the right type fiber optic, because without this, if you're relying only on your clinical acumen, the incidence of intraoperative hypoxia was about 40%. Now, with the with the FOB, it is less than 10%. So most of the adult DLTs you can manage with a 3.5 or a 4 scope. But for pediatric scope, you need a 2.8 or a 2.2. Okay, so we discussed about a margin of safety. What is margin of safety? It is nothing but the distance along the tracheobronchial tree through which the DLT can move without obstructing the major conducting airway. So whether it's a right-sided DLT or a left-sided DLT, the most acceptable proximal position is just distal to the carina, or the blue cuff just distal to the carina. So if your tube is anything more proximal, when you inflate, the cuff will herniate here, okay, and may obstruct this airway. So this is the most acceptable proximal position. The most acceptable distal position is when the tip is just before the takeoff of the left upper lobe. Anything beyond this, the tube tip may enter the left lower lobe. I will show it with one of the videos, or this cuff may come and obstruct the left upper lobe. So this can have two scenarios. One, your airway pressures will be high because if you are doing a left side ventilation of the left side, you are ventilating only this lower lobe with about 6 ml per kg tidal volume. Second thing, if the surgeon is doing the surgery on the left side, this left upper lobe may not collapse. Okay, and when you have a problem with upper lobe, the surgeon will become more upset and angry because he cannot manage with a uncollapsed upper lobe. Okay. For the right side, so as I mentioned, the margin of safety on left side is up to 1.6 to 1.9 millimeter. That is 1.5 centimeter. Sorry. Coming to the right side, the most acceptable proximal position remains the same. The most acceptable distal position is the tip cuff just before the right upper lobe takeoff. Anything beyond this, the cuff will herniate, obstruct the right upper lobe. Okay, so here you can see the margin of safety is very less. It's about 8 millimeter. Okay. The next major step is how you decide on the size. So it's primarily based on the height and the sex. So if you have a male who is more than 170 centimeter, you can go for a 41. Less than 170, you can go for a 39. Female more than 160, go for a 37. Less than 160, go for a 35. And many of our patients have short stature and height is less than 152. I will suggest, or the literature suggests that check the left main bronchus diameter. So how do you check the left main bronchus diameter? So Brodsky came up with a solution. He looked at the tracheal diameter of the thoracic inlet and multiplied with 0.68, which will give you the left main bronchus diameter. Or now that most of our patients have a CT scan, open the CT scan, measure the left main bronchus diameter, one cut below the carina. If it is at least 10, you can go with the 35. If it is less than 10, you may be better off with a 32. Okay. So again, now the next step is, once you have decided about the DLT, how do you go about it? You can see that the double lumen tubes have a proximal oropharyngeal curve and a distal bronchial curve, which are at 90 degrees to each other. So one of the reasons why novices struggle or inexperienced thoracic anesthetist struggle is because you can see that it's a long, broad structure. This is the outer diameter of a 8-sized single lumen tube, which is the normal maximum size which we use, and this is the 37 size. Okay, so it's quite big. And another small input I want to give here, especially when you're doing it for the first time, is this is the Y-shaped clamp which we connected to the double lumen tube. Okay, this is the connector. So if we had to collapse the lung, so first we clamp the tracheal lumen. So clamp on this part and not here. Okay, and then you open this part. So when it happens, we will ventilate the left side, and the right lung is open to the atmosphere, and it will collapse. So coming to the steps, this is how you prepare. I will allow you to play along. Okay, and in the meantime, I will show you how you do it. So you do a good laryngoscopy. You don't need to use a video laryngoscope. You introduce the double lumen tube with blue curve facing anteriorly, or the proximal bronchial curve facing anteriorly. And once it crosses the trachea, I will rotate it by 90 degrees. and advance till I get a resistance. Then you connect it and then inflate the bronchial lumen and start ventilating. Okay, so if you see what is happening inside, you should see the blue curve entering the trachea. Once the blue curve enters the trachea, you can rotate it by 90 degree and advance. So there's a bit of controversy whether to take out the stellate or not. If it's a new tube, it will have adequate rigidity and it will maintain the shape to go in. So if you're re-sterilizing the tube, some people prefer to have a stellate, but I will try to do it as traumatic as possible and take out the stellate. So coming to the clinical confirmation is done with auscultation. You do a bilateral auscultation. You should be able to hear air entry on both sides with the tracheal cuff inflated with about 4 or 5 centimeters of air. Once this is done, what you do first is clamp the tracheal lumen. Once you clamp the tracheal lumen for a left-sided DLT, you should not be here and open it up. You should not be hearing any air entry on the right side, and you should be able to hear air entry only on the left side. Okay. Similarly, at this particular point, we have not clamped we have not inflated the bronchial cuff. So there are two options here. One is try to hear for an audible leak and put about 1 to 3 ml of air in between. Other option is to put the patient on ventilator. If it's an adult patient, give a tidal volume of 300 ml and look at the expired tidal volume. So ideally, it should be within you can have only about 10 or 15 ml of leak. So titrate your bronchial cuff volume according to that leak, and that will be a good enough volume. So again, with the modern ventilator, you can actually see the airway pressures. So for example, if your airway pressure was about 15 and after you start bundling ventilation, it has gone to 35. That means it's probably malposition. The tube is probably too much in, because otherwise airway pressure should not be going beyond 30. And with more than a peak pressure of 30, you will struggle and can produce acute lung injury. Okay, so we should see the position appropriately. Okay, so there is a clinical confirmation, and you have to do with the other side. So when you unclamp the trachea and clamp the bronchial, you should be able to hear air entry on the right side and nothing should be on the left side. But this is clinical confirmation. And if you try to inflate with too much volume, you can hear a bit of sound on bilaterally. So that is why previously we had a hypoxia of about 40%. So now coming to the fiber optic confirmation, what you do first is to go through the tracheal lumen. Okay, when you go through the tracheal lumen, what you should see is tracheal rings anteriorly and trachealis muscle posteriorly, and you should be able to identify the primary carina. The tracheal rings anteriorly, trachealis muscle posteriorly, and this is the primary carina. Primary carina is the sharp structure. Okay, and once you cross the primary carina, you should be able to go to the right side and enter the right upper lobe. Right upper lobe has a typical trifurcation or a clover leaf shape, which is right apical, anterior, and posterior, and then you can go to the right bronchus intermediate. So it's very important. If you are not gone and visited Toronto General Hospital's bronchoscopy simulator, it's a good worthwhile exercise. Okay, once this is done, we have seen the blue curve just distal to the carina. That is good enough. Okay, so now you go to the other side. So you come out of the tracheal lumen. So here I have pushed the blue curve a bit more inside. Okay, this is for you to make you understand the margin of safety. Once I have done it, we'll go to the left side. Again, you clamp the left side. I'm doing it, I'm showing an unedited video because you need to understand that these things doesn't take time. Okay, so when you go to the left side, you can see a structure. Okay, is it a left-sided secondary carina? You can see this. Is it a secondary carina? I will say no. I'll tell you why. Okay, because here the tube was initially inside that part. Okay, that is the structure we were seeing. Okay, so you need to come here, and this is the left side secondary carina. Okay, there is a left side secondary carina. So a bit more inside, the tube would have gone the left lower lobe. So that is the margin of safety. Coming to the right side DLT, again, the same procedure. First, go through the tracheal lumen. When you go through the tracheal lumen, what do you need to see? You should be able to see the primary carina and the blue cuff distal to the primary carina. Then you enter the left side. Okay, so it's important for you to be familiar. Okay, this is the left-sided secondary carina. Okay, again, when you go through the bronchial lumen, okay, here we have an additional job. Here we need to make sure that the slot for the right upper lobe is aligned with the right upper lobe takeoff. So this is the bronchus intermedius, lingula, and the lower lobe. Normally, the trachealis muscle enters the lower lobe. So this is the slot. The slot needs to be aligned. Once the slot is aligned, we will be able to go inside and see the trifurcation. Okay. So this is the summary slide. When you go come through the tracheal lumen, you need to see the primary carina. Okay, and when you go through the bronchial lumen, you should be able to see the secondary carina. You can see the primary carina is sharp and secondary carina is broader. And when you come on the right side of the tracheal lumen for a left-sided DLT, you can go in and see the right upper lobe takeoff. For a right DLT, the only main difference is that on the carina, the tube is going to the right side, unless this picture on the carina, it's going to the left side. So this anatomical orientation of tracheal rings anteriorly and trachealis muscle posteriorly is important for us to determine which is right and which is left. Okay, so here we need to come and enter and make sure that this is aligned perfectly. If you have to troubleshoot. So one option is to turn the head to opposite side and advance. Other option is to pass a fiber optic and railroad, but you don't want to injure your delicate fiber optic. So what we can do is you can use the fiber optic like a GoPro camera. So what I do is I bring the fiber optic and bring it at the tip. Ideally speaking, you should be able to see a thin rim here like that. Okay, it should have been slightly more withdrawn, and then you can go in along. Okay, so that way you can manipulate with the fiber optic guidance. You can turn the head and turn the tube, and it'll work. Okay. So there is a new tube now. It's called an AMBU Viva set. It's nothing but a video DLT. When you say video DLT, the sizes are 30 adult size, and only left-sided tubes are available. You can connect it with an AMBU A-View monitor with the AC type connector, and it has got a CMOS camera which will give an image like this. So the main difference is that sometimes camera can have secretions, so you need to have a separate port where you can irrigate as well as do suctioning. So I have used it. You don't need a fiber optic, and the incidence of malposition is very less. And we found it very useful during the COVID times where we were worried about the fiber optic and aerosolization. So this preparation part, I will not go too much because I just want to show you one picture where when you connect it. Okay, so this is how easy it is. It automatically detects. Once you connect it, the light comes up and you can see the image on the screen. Okay. Okay, so when you go about Viva set DLT insertion, you need to understand that the camera is decided to have an anatomical position. So it is not a great camera for insertion. So when I have to insert a video DLT, I will insert it like how I go for a normal double lumen tube, either with a video laryngoscope or a normal Macintosh laryngoscope. So you can see that the uvula was at 3 o'clock position, and once you enter the glottis, then you turn it. Okay, once you turn it, the orientation becomes the anatomical orientation, and you start seeing the tracheal rings anteriorly. Okay, and trachealis muscles are not seen now. Now you can see the trachealis muscle, you can see the primary carena, and you get this view through the entire procedure. So once you have this view, you can practically avoid the intraoperative malposition, and if at all it happens, it's very easy to seclude it. Okay. So coming to the next part, which are bronchial blockers. What I'm going to discuss is about ARN blocker, Coop-Duct blocker, and EZ blockers. So this I will leave it. You can actually read it when you see the movie. Coming to the ARN blocker, these are wire-guided bronchial blockers. All the bronchial blockers in general have a higher pressure cuff compared to double lumen tube. Of the lot, ARN blocker is slightly better because these have a high volume, low pressure cuff, unlike a Fogarty. So the sizes available are 9, 7, and 5. And for a comfortable passage, you need a 7mm tube for a 7 French and 8mm tube for a 9 French. So the mechanism is a flexible nylon wire loop, and you have got an ARNT multi-port adapter. This is for the breathing circuit, this is for the fiber optic, and this is for the bronchoscope, and this gets attached to the endotracheal tube. So how do you prepare it? So for preparation, you can actually have it on a sterile surface, pass the bronchoscope to the bronchoscopy port, fiber optic through the fiber optic scope. I used a CMAC fiber scope for 4 size for a better video. This thing, you can see how I snare the one nylon loop here onto the fiber optic. Here, what is important is that you should have a good assistant. Okay, and when you have an ARNT multi-port adapter, you can continue to ventilate. So you don't, you are not in a hurry. The oxygenation and ventilation is taken care of. Here, what I mean is a good assistant is he should follow your hand movements very closely so that both of you go at the same time. And if you stop, or you should not withdraw, because if you withdraw, most probably it will come out. Okay, so we'll see what happens inside. So both of us go at this time. At this particular point, you are seeing, you're not seeing the blocker. So this part is actually blind. Once you come out of the tube, you can turn to the left side. So it's important again to have a anatomical orientation. You can see my hand movement where I have turned to the left side. And once it is in the left side and I identify the left side secondary carena, I can ask my assistant to unsnare it. Okay, he has unsnared it, and then you push it forward. So when you unsnare and push it forward, that is the time when you start seeing the blocker in front. Okay, you can see the wire loop. Okay, once you see this picture, withdraw the fiber optic beyond the carena and confirm that the blocker has gone to the left side. At this point, you withdraw the blocker and see the cuff just distal to the carena. On the left side, you are quite well off because you can, you know, it's about 4 centimeter. You can inflate maybe a centimeter down so that the chance of the blocker slipping out into the trachea is very less. It's a bit more tricky on the right side because sometimes its origin of right upper lobe takeoff is very close. Here you can see it is coming here. So you may have to inflate it here at the origin of the right upper lobe takeoff. It's important to fix the blocker properly. You can see that you note the distance because you can actually see the centimeter marking and you can tighten it here. Coming to the next blocker, which is a Fuji blocker and a Coop-Duct blocker. Both of them work on a principle of an angled tip. So here again, you should check the integrity of the cuff, and you should see that all these also come with a multi-port adapter, which is a slightly different design but works on the same principle. So here the assistant's job is to be a cameraman. He actually guides me. He doesn't have to do anything, but he should be a good cameraman. So we'll see what happens. So here you can see the primary carena and you can see the angled tip. So you can see that if you are gentle and you know how to torque it, you can see how you can rotate it and shift it to either right side or left side. So even if it gets intraoperative a malposition or dislodgement, it's very easy to place back. And these kind of devices can be done extraluminally also. You can use it through an LMA. So there are a lot of options. It's a smart device. So the next block is kid on the block is EZ blocker or an EC blocker. Unlike the previous one, it has got a Y-shaped tip, which is, and again, the entire thing is radiolucent, and it also has its own multi-port adapter. So you can check the integrity of the cuff, and it doesn't matter which side goes to which side. And how you do it is, introduce it through an 8 size or at least a 7.5 size in this plane. There is a coronal plane. Okay. So when you introduce it, it's better to lubricate it. Okay. And introduce. So you can see that the lubricant jelly, you pass it till you see a bit of resistance. When you have the resistance, you expect that the blocker has gone and sit onto the carena. Okay. So again, you can connect and ventilate. So you don't have to worry about desaturation. But one important thing is, before you do, you can access. Okay. So there is that much of resistance is only needed. That much. Whenever you use all these tubes, make sure that you don't put it too much in. That means, what I mean is, it should be at 4 to 6 centimeter above the carena. The tube should be 4 to 6 centimeter above the carena. So for a normal Indian patient, about 19 or maximum 20 for a female, and 21 for a male. That's good enough. Then the tube will be sufficiently away from the carena. The reason I'll tell you. So when you go with the confirmation, so you have realized that the blocker has gone to the left side. Okay. So how do you do it? So it's easy. You withdraw it back and hope that the blocker can be repositioned here. So here you can see that the tube is very close to the carena. So even when I withdraw it above the carena, you can see that the blocker is not opening. However, when I withdraw the tube, okay, it opens. So I will just show you once. When I withdraw the tube, now it's not opening. Just see here. When I withdraw, it opens. So this is why I was saying that the tube has to be at least 6 centimeter above the carena. Now you can inflate it and check it. And even if you're doing something like a bilateral wax, you can do it. So other option will be to chase it, like push it, follow it up with a fiber optic. Okay. So at all stage you are under vision. Okay. And you come out, see the carena. Once you see the carena, you place it under vision. Okay. So that is another way to do it. So you can see that it's very easy. It has got a slightly more better stability, radio opaque, and less risk of tracheobronchial injuries. Because if you pass AND or COOP deck blindly too much into one side, there is a reported incidence of tracheobronchial injury. So this is a summary slide. Again, I will not go into the details. You can see it, posting it at a later time. So there are certain pitfalls of bronchial blockers. If you're using it, there is a slow collapse of the lung. It's difficult to do suction. They are a bit more prone for dislodgement, and conversion to one lung ventilation, two lung ventilation, and one lung ventilation back can be difficult. That is, at the end of the surgery, surgeon may want to check for leaks. So he will ask you to say, okay, stop one lung and expand the lung, and he will put some saline there. So once he identifies the leak points, he will sort it out. Then he will say, to repair it, he will want the lung collapse. So he may do it 1 or 2 times. Okay. So the other thing is, it may take some time to collapse. So how do you do it? You can pre-oxygenate the lung nicely with 100% oxygen and continue both lung ventilation till you need one lung ventilation. So if you have to do the collapse, you disconnect the breathing circuit with the blocker in place for about 15-20 seconds or even 30 seconds. So what will happen? Both the lungs will collapse and come to your FRC position. Okay, unless there is disease and it takes more time. So once it's in that position, you inflate the blocker. Okay, balloon. So now once it is blocked and in place, you start a bit of recruiting and ventilate the non-operated lung. So if there is still a bit of this thing, you can apply graduated suction. So are blockers a substitute to double lumen tube? There are certain conditions where it has got a use, but when you're dealing with an absolute indication, double lumen tube may be a better choice. So I will conclude my first part, which is here. I will take about 5 minutes more and talk about the challenges of lung isolation techniques in pediatrics. The problems are that we don't have a double lumen tube smaller than 26. And even if you have to use a 26, you need a 8-year-old child who weighs at least about 30 kilos. And this is slightly more tricky in an Indian child because if it's 30, he may be obese. Okay, so basically you need at least 8 years. Again, Univen tubes are available at 3.5 size, but the outer diameter of that tube will be about that of a 6 millimeter single lumen tube. That is, you need again an 8-year-old child to do it. So what are the options in less than 8 years? So on blocker 5 French is an option, but you need a minimum of 4.5 millimeter single lumen tube. That is 2 years for a coaxial placement. So what can you do in less than 2 years? You need to probably think about extraluminal placement. So I will just show you a picture of how an 5 French on blocker is seen through a 4.5 single lumen tube. Okay. So now we'll pass a 2.2 millimeter scope. Okay. So now it you can see that it both together is occupying almost 90% or even more. Okay. So there was an excellent review article which actually talks about two important things. For the ventilation to happen, you cannot occupy more than 50% of the cross-sectional area or 70% of the diameter. For a reasonable introduction of fiber optic and bronchial blocker through a coaxial placement, the combined outer diameter cannot be more than 90%. So if you are in a situation like this where you are going to struggle, you may have to put the blocker outside. Okay, so we'll just see how we can do it. So if you, when I was training, most of the time, what my teachers used to do was, if you had to do a lung isolation in a child, they used to deliberately do an endobronchial intubation and pass a Fogarty catheter to that side. Once the Fogarty is in that side, you can withdraw it. Okay, and you cannot take the endotracheal tube out. So you leave that endotracheal tube on the Fogarty. And what you do is you fix it. You ask your assistant to fix it to the side of the face. Do another laryngoscopy and use a one size smaller cuffed endotracheal tube so that this tube can be, or the Fogarty can be kept in position. So that is what we used to do. Now I'm sure everybody, it has changed in all parts of the country. But for the sake of postgraduates, I'll just repeat. Okay, so these are the options. I will primarily concentrate how do you do it on extraluminally. So we still use Fogarty, but when you use a Fogarty, try and ask your surgeon for a arterial Fogarty. The importance of arterial Fogarty is that it comes with a stillet. This is a recommendation. So if somebody is less than 2, the recommendation is to use for a 4 French or a 3 French, but normally we go with a 5 French because it has got a larger balloon capacity. Fogarty balloons are extremely high pressure. So if you're using a larger blocker, you can manage with a lower pressure. Okay, and when you use an arterial Fogarty, you tilt the tip with about 20 to 30 degree. So this will make you use a Fogarty like a Coop duct or a Fuji bronchial blocker. So the next challenge which we face is if you pass the Fogarty coaxially, even if you take out the fiber optic, you cannot get a airtight seal here. Okay, so people have done different techniques. So one very useful technique which is described is before you pass the Fogarty, pre-oxygenate well and take off this connector and introduce the Fogarty. Okay, keep it in a good position and then you put the connector back. So the Fogarty will get jammed between the tube and the connector, and then you can get even though it is coaxial, you don't have to take it through the breathing circuit. Okay, and you need a three-way so that you can inflate the Fogarty balloon and then keep it closed. So I'll show you how we do the Fogarty extraluminally. So first we do a direct laryngoscopy and introduce the Fogarty with the direction facing left or right. You can do it blindly. I put it with that angle facing left side. It has gone to the left side. So then I use a sterilized ANT multi-port adapter so that it it can offer you an airtight seal. So again, here the crux is to keep the endotracheal tube about 4 centimeter at least above the carina or sufficient distance from the carina. So you can see the angle tip. So again, I will show you how you torque it. So you slowly turn it so that the tip is facing the right side now. Okay. You try to identify the angle tip somewhere here. Okay, now with the tip turning right side, okay, this part is the angle tip. Okay, it goes to the right side. And because we had to block the left side in this particular child, you withdraw it back. Okay, turn it. Okay, and then advance. So this is how it has to be done. So this is how you torque it. You should have one hand close to the child and one hand here. And the next part is ANT extraluminal placement. So here, what you do is, again, you can do a laryngoscope. You take the ANT blocker coupled with the fiber optic into it. So here, again, I'm talking about ANT extraluminal. So I'm not going through the ANT multiport adapter. I will just take the blocker, couple it with the fiber optic, do a laryngoscopy and introduce it in. One technique what we can do here is railroad the appropriate size ET tube prior onto the fiber optic. So I'll tell you why. So here you do a laryngoscopy, introduce that fiber optic plus ANT blocker. You see the carina. Once you see the carina, my fiber optic was not in the correct position. I get the orientation right by getting this marker at 12 o'clock. Then right is right, left is left. Enter. See the left-sided secondary carina. Once you see the left-sided secondary carina, I will disconnect or disengage the ANT blocker from the fiber optic and I'll push it in. Again, here we have to be very careful not to produce injury. Okay, once it is done, I will slowly withdraw it so that I can see the blocker here, come back and see the primary carina. So here again, it's important to have a very good understanding about the anatomical orientation. Once this is done, I will leave the blocker there and advance the endotracheal tube with the help of a direct laryngoscope. Okay, so because my endotracheal tube was already railroaded, I could do it like this. But you can see that the tube has gone to the left side as well. I will withdraw it till it's above the carina. So sometimes what will happen is you can see that the entire length of this video is like 1.5. So sometimes you may not be able to do it very fast. So in that case, once the blocker is placed, you can come out, oxygenate and intubate again with a left-sided DLT. So that is a very easy option. But again, I will say nice to have a nasal high flow to maintain oxygenation during you do lung isolation. One practical issue I have faced is if you have induced a child with sevoflurane and then give nasal high flow oxygen, the sevoflurane will wash out very fast. Okay, so if your indication is like a bronchopleural fistula or lung abscess or one of the child I have done is child who had multiple highlighted cysts. Post surgery, he had a significant leak. So we maintained the patient on spontaneous induce, and the moment you start giving high flow oxygen, child woke up because it got washed away. So it's important that we give it propofol and maintain your anesthesia. And this apneic oxygenation helps. So once you have intubated, you can connect an multi-port adapter. Okay. And like I'm going through the adapter, you can see the Haley's tubes green, Haylard's tubes green connector. And when you go inside, again, the anatomy is the same. You should be able to see the primary carina first. Okay. There is a primary carina. It has gone to the left side. You should withdraw it and fix it. I would like this part. I am not. Okay, I'll just probably wait for. It's only a minute. I'll wait. So this trying to do this on the left side is easy because you have a margin of safety. But right side it can be a bit tricky. The other thing is it may be worthwhile giving a bit of glycopyrrolate because if you have secretions, you will struggle with getting good images. Okay, you can see that there are a lot of secretions. So unlike an adult, you can see that the right upper lobe takeoff can be very close. So you will have the difficulty in keeping the bronchial blocker in position. The other issue I want to discuss is if you are using a 5 French or 7 French and you take the wire loop out, you cannot put it back easily. So if you are going to have a malposition, you'll struggle. So I will say that you leave the loop inside, and if there is a malposition, what you can do is you can do it in a manner like this. Here the blocker has gone to the other side, slipped and gone to the other side. How do you get it back? So again, if you have the tube like this very close to the carina, you will struggle. So what you can do is you can withdraw the tube so that you have sufficient length, okay, and have the loop in front of your tube, and then you pass the fiber optic through that loop. Okay, I'll just see what I'm doing. The fiber optic is passed, and then you can snare it. Once it is snared, you can take it to the left side. Okay. See the carina. And once you see the carina, you can push it forward. Okay. Now you can see the it has again gone back to that side. But that is only for you to say that as anesthetists, we are skilled. We can manage all these challenges. And with that, I'll conclude. Thank you so much.
Thank you, Dr. Raj, for an excellent talk. And I can see how proficient you are by the videos that you have made. And believe me, I'm excited to really get my hands onto all these equipments and help pneumonectomy and use all these blockers. I really remember how we used to struggle with the Fogarty catheter, and we did not even have a pediatric fiber optic. So I'm sure with the gadgets that are available now, the students must be really excited, and you made it look very simple. So thank you so much. Are there any questions?